Hey everybody, we'll get started in just about 5 minutes. Just let some people join in. Okay, we'll go ahead and get started. Hey everybody, welcome back. Thank you so much as always. We really appreciate all your support. We'll be hanging out at the end if you have any questions for us that we can answer for you. But aside from that, the quiz is going to be pretty straightforward as usual.
Yeah, the quiz will be given out at the end. There will be the link in the chat box, which you should see either at the bottom of your screen or to the right of your screen. It's multiple choice, 5 questions, and as long as you answer 4 out of 5 correctly, you'll get the certificate emailed to you.
Yeah, and like we said, if you have any questions about that or anything you want to ask us, we usually hang out for a bit after the video in case you want to chat with us directly. As far as the chat goes, please, we want to encourage you to be as active as you like in that. Any comment or question that you have, we will try and redirect them to Jessica somewhere throughout the PowerPoint. If not, you know, after one of the case studies, definitely at the end there. So definitely, please feel free to be as active as you guys like. But yeah, I think that is everything. Thank you guys so much for joining. We will go ahead and get started. Jessica, if you're ready on your end.
Awesome. Can you hear me?
Yes, ma'am.
Perfect.
All right, let me get the video started there. Hi. All right. Hey, everyone. So glad you're here. So I am Jessica. I am in surgical oncology, as I guess everyone knows by now. This is just going to be a quick run through of what I do exactly in the OR, in the hospital, in the clinic, and then 2, I call them case studies, but they're more just like a run through of how you get from one point to the other on 2 specific types of cancers that I see. So let's get started. About me. Actually born and raised in the Dallas-Fort Worth area. Some people know that, some don't. I actually stayed here. I went to UT Arlington for my undergrad. I majored in biology and I actually minored in music. A lot of people think you have to do total sciences for your major. You really don't. You can major or minor in whatever you want as long as you get the prereqs for PA school or whatever you're applying for. Most people here, or obviously all people here, are PAs. So I love music. I played the piano forever. I said, you know what? I'm going to do something else that I enjoy. I did have some time between undergrad and PA school, and I was actually a clinical research coordinator. I did plastic surgery research studies. So I did Botox trials, filler trials, some really cool things. And then I did go to UT Southwestern for PA school, which was my top choice. I loved it there. Personal info, I have 1 dog and 2 cats. If you hear any pattering around, it's probably the animals. I was able to make it home for this, and then really don't know how I got my husband to agree to that, but here we are. I do love to run. Before COVID hit, I was running a half marathon every month to month and a half, and it is the best stress reliever. Find something, whatever your thing is, if it's running or the gym or whatever, find something to blow off the steam. I've done a couple triathlons or a few of them. I did an Ironman. It gives me, I need a goal to work towards. Travel, I travel as often as I can. My poor husband, I'm always dragging him somewhere. As long as I have something on my to-do list or some place to travel on my calendar, I'm happy. Obviously, Corona's changed that, but. And then I was talking about the piano I have played since I was 5. That was my stress relief. It just, you don't really think, you're only thinking about the music. And then lastly, I'm really down for food and a good margarita. So probably go out a little too much, pre-COVID, I should say. Okay, now to the PA school stuff. Thoughts about applying. Keep your grades up. This goes without saying, but it's not the be all end all. Everyone says, you know, I need a 4.0, I have to have perfect grades. That's not everything that they're looking for. You know, a C isn't the end of the world. Grades aren't the only way you're evaluated. There's personality, there's how well you do under stress, there's your reference letters, your volunteer hours. And another thing about the letters of recommendation, don't just ask for a couple, ask for however many you want. Maybe you'll only get a few of those back. So ask, if you've been with someone, you have a valid experience with them, ask them. Volunteer in any way you can and use everything. I worked for years in my church nursery. I changed so many dirty diapers. Put that on there. That's a pediatric experience. Use everything that you can. And then, like I was saying before, personality goes a long way. How many just exceptionally smart people have you seen? And they've got 0 personality. So I feel like a PA, in one sense, sometimes have a better personality, and it counts for a lot. And then keep applying. If you're turned down once, apply again. Sometimes the committees will see that you're persistent and they will say, hey, let's give this person another chance. And I don't think I put this on here. No, I didn't. So what if you're waitlisted? Not very many people know this, but I was waitlisted. I don't know how far down the line I was. but I was waitlisted. I assume I would just apply the next year, and then I got in. So even a waitlist isn't the worst thing in the world. How I survived rotations. So like for surgery rotation, and I use that specifically because I'm in surgery, I would get to the hospital 4:35, leave at 6 or 7, sometimes later. I'd go right to the gym on campus. I would run, and this is terrible, but I would go to McDonald's. I'd get the 225 burger special, and I would study till midnight. And I would have coffee in the morning, a Coke, and an energy drink at lunch, an energy drink at night. I'm not sure why I didn't have some sort of a heart problem, but I do not recommend this. Speaking of playing the piano, I would go to the rec center. They happen to have a piano there in the gym, and I would play it for an hour or so and just forget about studying. And then study groups with my people. I am not good about actually studying with people. I get way too distracted. I start talking. I'm a terrible. I got in trouble in PA school for talking to my neighbor because one of the faculty noticed that during all of our lectures, my seatmate was named Teresa, and I would always be talking to Teresa. And my faculty member was like, maybe you should stop talking as much to Teresa. So I do terrible with groups. So I have to study on my own. And then once I get to the point where I've reviewed everything and I think I know it, then I would get into a study group in the last, couple of days before the test. And we would all review, and I could see what they saw that they thought was most important and that maybe I had missed. So it just helped to reaffirm some things and then add in a couple of other things that maybe I didn't go over as well, or they could quiz me on it. So that's the way I study. Everyone's different, but find your method. And then if you hate a rotation, just get through it. I hated my family medicine and my pediatric rotations. It was just the most trying time of my life. I dreaded it. I didn't want to go. Family medicine, God bless the people who are going to be in clinic all day, because if that is your thing, thank you. I cannot do it. I prefer my patients asleep. Okay, a lot of people ask how I got my job. So I knew from the beginning that surgery was for me because I had done plastic surgery before. I liked the personalities. I loved being in the OR. In addition, hating my family med rotation, that just said, okay, I know for a fact this is horrible. Because I'd gone into rotations thinking, let me kind of keep an open mind. I love surgery, but what if something else comes up? Let me just see what happens. So confirmed. And then I knew surgery was the end goal. I chose electives that would help me with that. So for my school, UT Southwestern, we had 16 months of rotations, some core ones like ER, family med, pediatric, infectious disease, internal medicine, surgery. And then we had 2 electives that we could choose. So I chose plastic surgery because I went back to where I worked and they let me kind of hang with them for a month. And then I chose critical care. I got to work in an ICU just north of Dallas. And it was fantastic. And then I actually got really lucky for my core surgery rotation. You would either get colorectal, vascular, or surg-onc, and I actually just got assigned to surg-onc, just luck of the draw. So I felt like the electives really, really helped me with my suturing, helped confirm that I knew I loved surgery as if I needed any more confirmation. And then critical care gave me a little bit of extra experience just managing some complex patients that I do now for my post-surgery patients. Those guys were the best. They loved to teach. They had a great physician group and a great APP group. So some PAs and some nurse practitioners that would run the nights. It was just the most supportive group. And I had talked to them. I'd thought about working there, but I couldn't get away from the surgery part. But the PAs there, they would put in chest tubes, lines, they would drain fluid on the lungs. They did so much. It was really, really awesome. I actually applied to just 2 jobs. I applied to one that was a lead through my old plastic surgery job. I wasn't super enthused about it. It was surgery, but it was kind of a subset in my plastic surgery department. It was mostly dealing with diabetic foot ulcers and wound care, and I was just not super thrilled about it, but it was a job. So I applied. And then my current boss, he actually sent out a job advert to my school because they would send jobs to alumni and the graduating class. And the email just said, surgeon in the Dallas area is looking for a PA. really no information about the hospital or the guy or specifically oncology. So I applied, I went in, I interviewed, he and I clicked, and then that was it. And I was really fortunate because his outgoing PA, we crossed paths for about 6 weeks. So I got to hang with her. I got to follow her around in her clinic. While I waited for my hospital credentialing to come through, I would observe while they were in the OR and see how she interacted with him, what her assisting was like. I would meet her for rounds. So it was really a good way. If you could get a position like that, it's ideal. Obviously, not everyone can, but it helped me a lot. And then I always hope if you can't get into what you really, really want, at least start somewhere. You know, if you can afford to wait, great. But at some point, you don't want to be too long between graduation and starting your job. Get into something like urgent care, do a bunch of procedures, and then just keep applying. And then also, y'all, on the other end, I don't have YouTube up. So if there's any questions that come through, just feel free to interrupt me and I can answer them, or we can wait at the end, whatever works for y'all.
Yeah, definitely. We'll keep you posted.
Okay, awesome. Okay, so here, okay, what do I do as a surgeon PA? There's 3 basic things: hospital, clinic, and then surgery. And when I interviewed, my boss asked me, he's like, where do you see yourself in this position? You know, what do you want to do? And I told him, I was like, well, I would really love to be in the OR. I said, and then just a little bit of hospital, a little bit of clinic. And I think I said the clinic part just to kind of say the right words, because if you know a surgeon, you know they hate being in the clinic. It's a necessary evil. It's what you have to do. So I kind of said that, and he's like, okay. And that was kind of it. So it turns out that's exactly what I do. So my time in the hospital is probably not separated in thirds. I probably spent a little less time in the hospital, maybe 15%, maybe 20%. I round on all the new consults. So I'm still technically working today. I did not take a day off. I was rounding this morning. I saw a couple, I actually saw 2 new consults and a post-op patient. So I put the consult note in with our recommendations, any orders associated with our recommendations. And then if the service that consulted us or one of the other consulting services needs an update, I'll call them or I'll call the APP for that group. So like, for example, if they consult us on an obstructed hernia, and, we look at it, hey, okay, we can reduce it. And reduce means, actually, let me start at the beginning. A hernia is basically a hole and stuff can get caught in there. And a hernia by itself isn't necessarily always a problem, but if you get something stuck in there, like a piece of intestine, it can get locked in there and lose the blood supply, and that intestine can die. So that becomes an emergency. So if I go see a new consult for that, I have to determine, is this a surgical emergency? And if it is, I will usually update the team that consulted us. It's usually the hospitalist. And I'll say, hey, here's what I think. We're taking them to the OR. I'll let my boss know unless he's there with me. We'll book the OR. We'll let our scheduler know. So it's basically, I update them if there's something that they need to know quickly. And then I round on post-op patients. I review the labs, review the vitals, make sure the patient's progressing. Are they getting a wound infection? I can give you all some, I don't want to break any privacy laws. I can give you some things like we'll have a patient that was doing well, 3, 4, 5 days out of surgery. All of a sudden their infection counts, their white count starts going up, and they're walking in the hall and the nurse calls and said, okay, hey, all of a sudden they felt weak and dizzy and short of breath. Well, we're going to immediately order a scan of their chest to make sure that they don't have a blood clot, because that's one of the big things that can happen. People can get pneumonias and blood clots after surgery. So basically, you're just going to check on your patient and make sure nothing's happening. We usually have a hospitalist group as well, and they manage kind of everything else. Is the patient a diabetic? Do they need some heart medications updated? Our hospitalist team is fantastic. We have an auto consult and they help us with every patient. In a way, it's bad because I don't do as much medicine as I would like because I want to stay fresh on it, but it's really, really handy to have them around because they're in-house 24 hours. So if anything goes down in the middle of the night when my boss and I are not there, there's always a doctor at the hospital to take care of them. And then I work with PT and OT, physical therapy and occupational therapy. I consult them for most of our patients. If we have a breast patient, they had a mastectomy, so their breast was removed, I'll get physical therapy and occupational therapy in to work with them on arm exercises. You want to make sure they can still lift their arm after surgery. And they will give them a list of exercises, they'll work with them, and they'll say, hey, start doing this or doing that. The PTs and the OTs are fantastic. A side note, at UT Southwestern, I actually went to school with the PTs. They have a doctor of physical therapy program. And when we did our anatomy lab with the cadavers, we were all with the PTs and the OTs. So I got to know them really well. They're awesome. I respect them. I consult them as often as I can. And I take their recommendations to heart. I work with social work. Social work is going to help you if maybe an older patient needs to go to rehab or an assisted living place and they can't just go home from the hospital. Social work helps us with that. If my patient has a feeding tube in and they're going to need that formula to go home with them, social work gets a home health agency, some infusion people, they get them involved, they make sure insurance approves it. And then RDs are registered dietitians. I rely on them to give me the recommendations in terms of what sort of formula needs to be in. Do they need a little bit of extra electrolytes here? Do they need more calories? So the RDs help me with the social work. Wound care, we have an ostomy nurse at my hospital. She's awesome. She'll change wound vacs, she'll check out ostomies. An ostomy, again, I know some of you are pre-PA, so you're still in college, but an ostomy is basically, if you think of the patients with the bag, it's a bag hanging out where their intestine comes to the surface, either small bowel or colon, depending on what kind of ostomy they have, and their bowel movements come out through there. And so the nurse this wound care nurse helps them, teaches them how to change that so they're not afraid of it and they can look at it and say, okay, here's what I do. So I work with all of these people. It's interesting because a lot of them will sometimes come to me because they hate bugging the doctors. My boss is actually really cool, but sometimes they hate bugging the doctors. So they call me all the time. I can't tell you how many people on our floor have my cell phone. The nurses just, they call me because they prefer to do that than go through my office and page me that way, because nobody really uses pagers, or we don't use pagers anymore. It's just my cell phone. In the clinic, the bane of my existence, all the post-op patients I see. So all of them go on my schedule unless the patient is, requesting to see the doctor, or maybe it's something where they have something super serious and they really need to see him. If it's a patient that's a little kind of odd, doesn't love me, I'll go in and I'll see them. And then just to kind of make them feel better, I'll bring my boss in. So he and I have clinic actually the exact same time. And then he and I split the routine follow-up. So we'll see patients who've had a breast cancer, whatever surgery they have, we still follow them every 6 months for at least 5 years. Mastectomy patients obviously don't need mammograms, but if you had a lumpectomy, which is where you don't remove the whole breast, you just remove a portion of tumor, they need mammograms. The rules have changed. The mammograms are now once a year, but we still see the patients every 6 months to do a breast exam. Will you do wound checks? Sometimes patients who've had a wound vac in, they need to be seen every week, every couple of weeks. So I'll see them, I'll have them see my boss the next week, and then I'll see them the week after. And then I see a lot of the urgent add-ons. If it's a problem with a feeding tube, if there's an abscess that needs to be taken care of, which is just a pocket of pus, with skin infection. Seroma, we'll get those sometimes that is a pocket of fluid. If we operate on, again, a breast and we take a lymph node from the underarm, you can get fluid where that lymph node was, and that's called a seroma. And sometimes I'll numb them and stick a little needle in there and draw the fluid off. So that can kind of come up out of the blue. And then, like I was saying before, my doc and I, we actually have clinic on the same days. So he comes in to help me, I help him. Sometimes he's doing a procedure, maybe he's taking a lipoma out, I'll come in, I'll actually assist him, not that he really needs much help, but I'll cut his suture and then I'll do the last layer of closing so that he can go on and see his next patient. Sometimes if I don't have a whole lot of patients on my schedule, I'll just go in and just be his chaperone. I know some people are kind of opposed to that because you're not paid to be a chaperone. It doesn't bother me. I between patients, why not, I guess. And that's what I think. It depends on the intent with your doc. If he's just using you as a chaperone or a scribe, well, that's a problem. But my boss actually respects me. We have a great relationship, so I don't mind going in with him to do things like that. We work really well in clinic together. And then OR, obviously my favorite place to play. I am the first assist on all of the cases at 3 of our 4 hospitals. And I say all of them, it's probably 95, 99%. If it's something, we put in ports, which is a chemotherapy. It's like It's a inserted peripheral line. So it's a deep catheter, but it's not sticking out. It's underneath the skin, and it's how chemotherapy is given. So he puts that, he doesn't need me for that. There's nothing I can add to that. But pretty much everything else I do first assist him. 2 of those hospitals are small outpatient centers. So we do little hernias, little lumpectomies. And then the other hospital that I help him at is our big center where we do take out esophagus, take out a stomach. Patients are spending 3, 4, 5 days there or longer. And then the other hospital is the teaching hospital where we have residents. I don't go there because he has the residents helping assist him. I do go for robot cases because the residents do not assist at the bedside for a robot, and usually they're working the controls. There's a double console for my boss to show them how to operate. So I am at the bedside for robots. My boss doesn't go there very often. He goes, I don't know, sometimes once a week, every other week, not very much. And then I'm the buffer between the surgeon and the staff. I work with the circulator, I work with the scrub tech, we make sure everything's pulled. Do we have all of the supplies? Is it a new hospital? They need to know what gloves, just because every surgeon has different preferences. Some are super picky. I guess all of them are picky, they're surgeons. And just to make sure that, you know, they may pull a certain kind of suture that one doctor likes, but my doctor doesn't like. So I'm there to say, hey, let's get this one. No, let's get that. You know, when we close the incision, my boss has this particular type of suture he likes. I'm always trying to make sure I go pull that. Well, I guess I don't pull it. I let them know. And whatever they pull, I said, yes, that's the one we use. If we're injecting a local, so a numbing medication at the end, I make sure they have the correct setup for that. Surgeons are notoriously impatient. My boss is pretty good, but he can get impatient sometimes. And it's easier for them to come to me because I'll answer all the questions. So they're always asking, you know, how do we position the patient? Do they need to be on their side or on their back? You know, here, what's the stuff that do we need? How do we prep it? How do we set them up? So I love all the staff we work with. They're fantastic. And then after the case, I put in all of the orders. So all the postoperative orders, I put those in. I write a postoperative note. My boss dictates the true operative report. I make sure that all the meds are set up. Anyone I need consulted is consulted. I put in the pre-surgery note, which is the H&P, the history and physical. I make sure that that's documented. Everyone has to have a note within 30 days. I confirm that. I joke with the hospital because I'm always there before my boss, and it disturbs me if he gets there before me just because I like to be on time. So I'm always there early, and there's always a nurse in pre-op who says, you know, where's your boss? Where's your man at? And I tell them, I was like, I am not responsible for that man until he is here. His wife is responsible. So we laugh about that. Once he's at the hospital, then I keep track of him and, you know, remind him to do this or that. But like, I feel like I'm saying it over and over, but we do have a really good relationship. Call days. Today is actually a call day. So we take, and a lot of people don't realize this, we take general surgery call a couple times a month, 3 times a month. It varies. It is actually 24 hours. So it's from 7 a.m. to 7 a.m. the next day. So we start at 7 a.m. this morning, and it will actually, we're doing 2 days in a row. So it'll end at 7 a.m. on Friday. So I usually answer all the calls during the day. The ER will call my office, they'll consult us, or page us, I should say. I call them back, whether it's the MD in the ER or the APP in the ER. And if anybody doesn't know, APP is Advanced Practice Provider. It stands for PAs and nurse practitioners. They were using mid-level, which I know to some people is insulting because we don't provide mid-level care. We provide excellent care. So anyways, they've started calling people APPs. So if I use that term, that's just kind of what I'm referring to. And then my boss takes all the night calls. So after 5, it goes to the answering service and they page my doc. They will occasionally call me if he's sleeping through a call and doesn't pick up, since they've got my number as well. I've been woken up at 2 a.m. a couple of times. We can get called for any sort of general surgery emergency during this time, whether it's an incarcerated hernia, which I was explaining before is something stuck in the hernia, a bad appendix, a bowel that's popped open, so perforated, a gallbladder that's gone south on someone. It doesn't have to be oncology, and that's what people have asked me about. Oh, you do more than oncology, and we do. And I think, so part of the reason is my boss he likes to keep busy. So we're pretty busy, but also this helps our call group. We split the weekends with about 4 other surgeons. So every 5th weekend, one of these surgeons is on call, and they cover the patients for all the other 4 surgeons. So this ER call is split with those guys and girls, and this gives them kind of a break too, if everyone kind of pitches in and covers the 30, 31 days of the month. And then we're also consulted for any surgical oncology problems on in-house patients. So one of my patients today that we were consulted on was a surgical oncology issue. And then the other one was an ER issue that's non-oncology related. So even if it's not our traditional ER call day, we can get called for surgical oncology because there's only 2 of us that are GI surgery in the hospital. There's a couple colorectals, there's a head and neck guy. So it really kind of depends on where in the GI tract the problem is. And then when my boss takes time off, and this used to be the most stressful time of my life, I do take all the calls that come in 24/7. Everything during the day that the office sends me, I have to triage. It usually goes to the MA if it's something easy like paperwork, and then she sends it to me if it's a patient problem or something that she can't handle, and then I take care of it from there. I can bring a patient in to see them in clinic. I can call them back. I can send them antibiotics if they've got an infection and have them come in and see me. And then if there's something that I need advice on, like something I would ask my own boss about, or if a patient needs to be admitted, I always have a covering MD. First of all, legally, you need someone. I've put them into my medical boards, my state medical board listed them as a covering physician. So I can still technically call them at any time, but you need a supervising physician. So I have always had my guy to call, and he's really awesome. He's basically the same as us, and he works just north of us. He helps me out a lot. And so it used to be pretty stressful, but as I've been in surgical oncology a bit longer, I'm able to do more than you know more than you think you do. And that's what I've told people about rotations. So you go in not knowing, oh my God, this is gonna be terrible. It comes out. It's hidden in there somewhere. And when you are stuck trying to answer, and that's not just someone you can ask, you realize you really do know the answers to these. So it's actually become kind of nice, almost a little mini vacation, because I go to clinic and I go to the hospital, and the manager in our office she doesn't know where I'm at, and she doesn't care, and she's super chill. So I do my work. I work from home, and it's become a lot easier when he's gone now. And then what do we do in C? For us particularly, mostly GI with a little bit of everything else sprinkled in. So my boss and I like to joke, we do everything except for the entrance and the exit. So we do esophagus, stomach, small bowel, right colon, and appendix. We'll do some transverse colon, which is the colon that goes kind of across, but we don't do like rectal cases, liver, spleen, pancreas. We do melanoma skin cancer surgeries. We do breast. We do lumpectomy and mastectomy. We work with the plastic surgeons if people are wanting reconstruction. We place feeding tubes when people have head and neck cancers or esophageal cancers, ports, like I was saying before, for chemotherapy. And then, as I mentioned before, we do general surgery stuff, not only on ER call days, but also some of the surrounding primary care doctors will send their patients to us. Appendix isn't necessarily something that's going to be sent to the office, because usually that's going to rage and broil within a few days. But if it's something where a doc scans a patient on Monday and we're in clinic on Tuesday, if they're not horribly in pain, sometimes they'll send them to us the next day, but usually we just book them for surgery. We'll get some gallbladders, some stones, gallbladder stones, hernias, some lipomas, which are just fatty tumors. We do quite a bit. We're very busy. So let's go over case number 1. Like I said, these aren't typical question and answer sessions. They're just more kind of an informative of things that we see. So let me move this so I can, there. Okay, Mr. B is a 60-year-old male. He presented, and in this case, I'm going to say to the primary care doctor. And I'll kind of tell you how people get to us. Let's move this because I keep looking down at the bottom of the screen. And chief complaint. So CC is chief complaint. When you get to PA school and you see the notes, you'll see that. What brought them in? Is it abdominal pain? Is it what is it? So in his case, 3 months of just worsening difficulty with swallowing. He first noticed it with solid food. He had a burger, he choked, felt like he couldn't swallow it. And then it just kept getting worse to where now he can only have liquids and he can't have solids. And those are the key words there. Like if you're reading a story, a history on something, they'll say progressive dysphagia. So worsening problems with swallowing. Lost about 20 pounds. He does have a history of reflux. He's taken some antacids, does not feel that they have helped because his reflux is worsening. So I know what this is because this is what I deal with all the time, but a primary care doctor may not. So what's going to be the differential diagnosis if you're in just Dr. Cook's office, primary care? Well, if you think about the esophagus, it's a tube between the mouth and the stomach, just really simple terms. They could have a stricture or an ulcer. An ulcer is a burned out spot, basically. A stricture is a tightening. Instead of an opening like this, the opening is like this. They could have esophagitis, which is related to GERD. So GERD is reflux, bad acid. Esophagitis is where the esophagus is burnt from the reflux. You can have motility issues. Maybe that esophagus doesn't move really well and stuff just moves slowly. Or you could have, and you know the answer to this, it's going to be esophageal cancer because obviously that's what I deal with. But a primary care doctor doesn't know that. So they're going to say, hey, you know, what could this be? I've seen a lot of cases where someone presented like this, not so much this dysphagia, or the problem's eating, but saying, hey, look, I choked once and then I was okay, but my reflux is really bad. And instead of kind of moving on, these patients will be given a double dose of antacid or a different antacid and some nausea medication sent on their merry way. Maybe they'll improve for a little bit and then worsen. Well, if it's cancer, it's obviously never going to get better. So what do you want to do next? I put these on here. None of these are really terrible because the patient's basically going to need all of these. But if you're in a primary care office, usually the best step is going to be to get an upper GI. Do I have? I guess I do. So an upper GI is a way of, it's basically an x-ray with some dye. You have the person swallow some dye and then they look at the esophagus and they can say, hey, is it open? Is it tied down? What's going on with it? If they did a CT scan, the patient's going to need that anyways in the setting of cancer. So it's not necessarily the worst first step in the world. You may see some thickening around the esophagus, but you're still going to end up doing something else. But like I said, a CT scan is good for workup overall because if this person has spread of disease, metastatic disease, you want to find that. Is there something in the liver? Is there something in the lungs? And then an EGD is automatically going to be your second step. You do the upper GI. Let's go here. And here we've got, so you decide to proceed with barium swallow / upper GI. If you don't know what you're looking at, this is going to be a little bit difficult. And I think they said my marker. Good. If you look at this, the colors of the arrows are more just showing stopping and starting points. This is the esophagus here. And you can see how it gets really thin right here. So they swallow the contrast and then it's just barely getting through. This is why people stop eating the solid foods and they go to liquids because nothing's able to get through here and they're choking and then they're vomiting and they're just miserable. So obviously they're going to liquids and they're losing a lot of weight. So you see this, you're immediately going to want to scope someone. You say, hey, there's something that's sitting right in here. Let's figure out what this is. It's going to be a cancer, right? So you refer them to a GI doctor and they get a scope. I guess that's the question. So where do you go next? Where do you proceed? You need to know what we're dealing with here. You assume it's going to be a cancer. You need tissue diagnosis, which means you need a chunk of tissue. You need to look at it. You need to make sure it is a cancer. Because what's the thing you don't want to miss? What if that upper GI looked like that because the esophagus isn't moving really well and the muscles are kind of wiggly and it just caught it at an odd time and it's not a cancer? Okay, fine, but you don't want to miss a cancer. So you're going to send someone for a scope. An EGD is a camera put down the mouth. It's like a colonoscopy, but up top. Put down the mouth and it looks down the esophagus and it checks to see, is there a mass? So if you're looking at this is basically the camera just looking right down someone's mouth. This here, this is tumor. This is a big chunk of tumor and you can see your hole should be kind of like this. Oops. Your hole should be like this. And now it's like this. So very little is able to pass through here. So you can imagine how stuff would kind of get caught, not getting down. You feel this tightness and this thickness in your chest, and now you're spitting up. So some of these people presented with chest pain. It's obviously not their heart, it's this. So what the GI doctor will do is they'll take a little chunk of tissue from here, and they'll send that to a pathologist, and they'll give us a diagnosis. What type of cancer is it? And when they do this scope, they've actually got an ultrasound, and they can look and see how thick this cancer is. Are there any lymph nodes that are around here, just outside of the esophagus, that may have tumor in them? And then now that you have a diagnosis, you're going to get scan for staging. So when I was talking about earlier, you know, if you got a CT scan first off, it's not necessarily the wrong move because you're ultimately going to need that. But you want to know, is something lighting up? This is not, again, none of these pictures are my patients. This is stuff I've dragged off of the internet. But you'll get a CT, and then or depending on the doctors you'll get a PET scan. Usually patients, the primary care doctor is usually out of it. They're sending them to us, they're sending them to a chemo doctor. So if you look at this on the right side, the way to explain a scan that's like this is someone is laying on their back like this, and they're cut like a loaf of bread. So if you're looking at this picture here, you're standing at someone's feet, they're on their back, and you're looking up, and they're sliced like the bread. So if you look here, lungs, this is your spinal column. So again, they're on their back. The bottom picture is someone a little bit further down. This right here is their liver. And if we saw that on our patient, these bright spots are cancer that's gone to the liver. And you can use that to say, hey, is this person going to be resectable potentially or not at all? In order to have surgery, in order to take out an esophagus, you cannot have metastatic disease. You can have some local disease, like maybe a couple lymph nodes around the esophagus are involved, but you cannot have spread. Studies have shown, you know, once you get to this point, you don't want to put someone through surgery because the cancer's already spread from the main site. And then this right here is basically a person standing up, and you're just looking straight on at them, and you can see a bunch of spots in their liver. This is, I think this photo I got was from maybe some melanoma. Maybe it was esophageal cancer, but it's going to light up that way. You can see spots up here lighten up. Usually you're going to see the contrast or the lighten up in the bladder as people pee it out. The contrast is excreted through the kidneys, so that's going to light up. The kidneys light up. A CT, the difference between a CT and a PET scan, a CT is great. I like to tell people it looks at, I can look at vascular, I can look at like basically the vessels, I can look at lymph nodes in particular. If we're looking at a pancreas cancer, can I get that out? Because is it near the big vein or is it around the big vein? And that's going to be the determinant factor on if I can get something out, you know, veins and arteries. A PET scan is good for large things. Is it in the liver? Is it in the lungs? You're not necessarily using that to determine, hey, how close, you know, can I get through those two things right there? But both of them are, you know, really helpful in their own way. So at this point, the patient is already obviously all in oncology. There's a couple of ways of treating this esophageal cancer. They have their diagnosis. Okay, so now what? We're going to assume for this discussion that this patient's PET scan was clear, meaning the tumor is all in their esophagus. It's not in their liver. They look like they could ultimately have surgery, okay? So they're going to visit with a radiation oncologist. Radiation can be used before surgery or after surgery. There is a certain amount of radiation that patients can get. So if they get it before surgery, they usually can't have it afterwards. Radiation can shrink the tumor. What if a patient has a big tumor that's just so big and ugly, it's bleeding? Radiation can actually help stop the bleeding. What about a tumor that's unresectable, meaning they've got liver spots, or maybe it's invading into something close by that you can't get out? Maybe, you know, there's a lot of different things, but sometimes a bone or something. Radiation can be used palliatively to kind of help them feel better. Palliative means nothing you do is going to be curative, but let's give them the longest possible life with good quality of life as we can. Or definitively, some esophageal cancers, there's adenocarcinoma and then there's squamous. Squamous, the way it responds to chemo and radiation, usually people don't get surgery just because it responds a lot better. So it can be used definitively as opposed to palliatively in squamous cell. And then for our part, for the surgery part, we usually take the patient to the OR. We do a laparoscopy and a port and sometimes a feeding tube. So that just says we put a port in for chemo that I've talked about a couple times. A laparoscopy means we take a couple of looks inside, a couple poke holes with a camera just to make sure if their scan was clean, let's make sure there's nothing hidden. And I'm going to go over that in just a second. And then sometimes a feeding tube. If you've got someone that's got cancer, they're going to go through chemo. They've already had trouble swallowing. They've lost some weight. We'll put a feeding tube in them to keep their nutrition up during the chemotherapy. And then we always look for possible hidden disease. One of the most disappointing things in my job is a scan that looks just fine. It looks beautiful. Okay, this patient can go to surgery, and we'll go in with a camera and we will find metastatic disease. And it's because sometimes it's just like little sprinkles of sand and you can't see it. So that's actually pretty disappointing at times for the patient and for us, because that basically says no surgery for them. Here's a great example. Do I have? Yes, I do. This is during a laparoscopy. Like I said, you put the poke holes in. This is going to be like the lining, so the peritoneum, so the inside of the belly. This looks like a piece of colon here. This is not my patient, obviously, but all these chunks here, this, that is cancer that's sitting right there on the patient. So that probably would have showed up on a scan, but we go in and we'll take tissue, and that says that we're not going to operate on them. Here's another one. This, and this. These are cancerous spots in the liver. Sometimes people will need to get that radiated, but if we saw that and it was esophageal cancer patient, we would not be operating on them. So after the laparoscopy, they are going to go, do their chemo, maybe the radiation, maybe not. And then about a month to a month and a half after they've completed treatment, it's back to us again. We take them to the OR for an esophagectomy. So what'll happen is they finish their chemo, they get some restaging scans, make sure their cancer is shrinking or at least staying the same, make sure it hasn't grown. They come with those scans, we take a look at them, and we talk to them about surgery. And it is imperative that they come see us because an esophagectomy is a gigantic surgery. It's about 20% risk of having some sort of a problem happen. The surgery is about 5 to 6 hours. We do it in conjunction with thoracic surgeons. And we will cut, I've got a picture in a minute. Actually, okay, here we go. Here's your cancer. A lot of them are down here in the bottom third of the esophagus where it connects to the stomach. And what'll happen is we're gonna cut, this one's a little bit high. We try to avoid that if we can. We usually cut closer to down to here and then the top of the stomach. So patients are left with an actual, 75, 80% of the stomach in most cases is left. And what'll happen is we cut down here, cut down here. We do the belly portion first. This is where my boss and I come in, cut, kind of free up all of this, and we actually stuff the stomach up into the chest. We go to the right side of the chest. And we have the thoracic surgeon come in. We turn the patient. We actually drop the lung on this side, and we bring the stomach up and connect it to this cut portion of esophagus. Again, it's further down here. So these do take, like I said, 5 or 6 hours. We keep the patient from eating for 4 days. Everyone is different. I know some doctors don't let their patients eat for a week. Us, for it's 4 to 5 days. Everyone is different on how they proceed, but this is how we do it. We don't let them eat for 4 days. We scan them with some contrast to make sure that this hookup is secure, because this is one of the big things that can happen is right here where things are stapled together. If that does not seal, you'll get leakage and patients can get really, really sick. So we want to make sure that that is sealed. And during this time, this is an ugly feeding tube, but yeah, our patients have a feeding tube, and that's how they get their nutrition while they're in the hospital waiting for things to seal. Long term, actually, there's no dietary restrictions. I see all the patients post-op for these. Usually ends up being about 3 weeks post-op. And I send them home with their feeding tube, but not using it. So we kind of gradually move them on from clear liquids, so water, juice, and then I let them do thick liquids, so protein shakes and soups. And I send them home on that, and I have them do that for 5 to 7 days, and then I have them go to soft, mushy foods, so low fiber, no popcorn, everything cooked and soft. And so when they come to see me at post-op, they can get in enough calories on soft foods and protein shakes to survive. And if they're doing good and they have not needed to use their feeding tube, I actually will remove it at their post-op visit. Most people hate it and they're ready to get it out. And then I tell them to just start slowly advancing. By 6 weeks after surgery, it's okay to be eating whatever you want as long as you feel okay. Depending on how much stomach is left, some people can get dumping, where if you get a lot of sugary foods like ice cream, sometimes it'll run through pretty quickly and people will end up in the restroom. But I tell people I can't really predict who that's going to happen to. So just eat whatever you want and see how you do. If you have a problem, okay, we can manage it. We can talk about it. But for now, just try and eat whatever. And most of my patients do end up just eating whatever. They obviously start with small meals because their stomach is not working as well. We took a bunch of it and they have to get used to that. The problem with a lot of patients is they try to eat what they normally do and they just get to that tipping point and then they vomit. So I tell them just eat all day long, breakfast, lunch, and dinner and snacks. Eat less and eat all day long, and you'll kind of, your body will get used to it. And then depending on the pathology report, their oncologist will decide if they need further chemo. Most of these patients, esophageal cancer, most of them are going to get more cancer, unless you get some sort of tumor that just responded amazingly well. But even then, the oncologist is going to say, hey, if your body responded that well, let's just, give it another kick at the pan. So most people will get chemo, unless, like I said, there's a couple of sometimes no, but most will. Here's the sad thing. Overall survival is about 20%. And that's overall, that's everyone. If it's localized, meaning the esophagus only, it's about a 47-ish% chance, a 5-year survival, I should say, is about 47%, which is sad because, about half the people we operate on are going to make it and half, it's going to come back in the next couple of years. If it's spread to some lymph nodes, about 25%. And then if it's distant, liver, lung, whatever, it's about a 5%, 5-year survival. So not the greatest. Those numbers are getting better. Over time, we're getting better chemo. It used to be you give someone chemo and you'd look at the pathology report after surgery and there's cancer in all the lymph nodes. The cancer is still big. And now I'll get some pathology reports and there's no cancer in the lymph nodes. And they can look and they can see where the tumor was in the esophagus, and it's shrunk so well because it responded to chemo. So there obviously are advances, and hopefully those numbers keep going up. I think that's all. Yeah. So that's all for case number 1. I think I'm droning on a little bit longer than I meant. So let's go to case number 2.
Hey, Jessica, real quick, if you don't mind.
Yes.
There's a ton of really good questions. A lot of them are more general, so I'll hang on to them until the end. But there were a few questions on the case study 1.
Oh, yeah. Let's do that.
Okay, perfect. So starting off, Brenda wants to know, why can't you operate on patients with metastatic cancer?
So let me go back to this. Okay, let's do this for an example. We can go in and I can take out the esophagus. And let me clarify also, this is specifically for esophageal cancer. I'll kind of give an explanation on operate on other people, but in general for esophageal cancer, if it's spread outside of the esophagus and it goes to the liver, yeah, I can take them to the OR, I can take out their esophagus, but how have I helped them? I did not remove all of the cancer. The way to make the surgery worthwhile, I guess if you say, is if you can actually rid them of their cancer. If I go in and I take the esophagus, well, look right here. They still have a bunch of tumor in their livers. So I'm subjecting them to a 6-hour surgery, anesthesia, a dropped lung, because we dropped their lung during surgery on purpose. 5 to 7 days in the hospital, all this, problems, the risk of having, a leak, like I was talking about, all those problems when I have not cured their cancer. I have not taken the whole thing out. Some cancers, you can do that. So for colon cancers, a lot of times, so these Mets right here are from colon cancer. We will do that. We'll take out the part of the colon and we'll go in and we'll either burn these spots or we'll take them out or we'll put little markers so they can get radiation. So it's really more of a cancer type, but esophagus, no, we're not going to do it. I'm not going to make that person go through that when I have not cured them. Another thing we'll do is HIPEC, which is if someone has cancer like this, it's all in their belly, or even like this, we'll go in and we'll scrape all tumor and we'll pour chemo on that. It's called intraperitoneal chemotherapy. So I guess the answer to the question is it depends. In esophagus, I answered that because you you want to make their life worthwhile and not hinder them. But for other types of cancer, you can. It depends on where the cancer is and what type of cancer it is.
Perfect. Thank you for clarifying. Valerie would like to know, is the esophageal sphincter still intact during this procedure?
It is not. So that's actually a really good question. So it's the LES, the lower esophageal sphincter, which is right there. So when we cut, that is removed. So the reason it's a good point is because all my patients, I tell them, you don't want to eat 2 hours before bed. And when you go to bed, you actually want to be propped at a 45-degree angle because you have nothing stopping that food from coming right back up. So if they stop eating before bed, that can help because stuff moves through their GI system. And then if they prop themselves up, they're basically using gravity, preventing it from coming up.
Perfect, thank you. Somebody's asking, do patients still crave food while they have the feeding tube in, or are they in too much?
They do. Yeah. And it's, I don't know if it's a psychological thing. And it could be a hunger thing because you have your stomach and your stomach is empty because the feeding tube actually goes into your small intestine. So your stomach's actually empty. We have a tube in their nose that's sucking things out. So they do say that they're hungry, but on the other side of that, you've had cancer, you've had chemo. Some people don't have much of an appetite. So yes, some can be hungry, some aren't. The feeding tube gives them the calories. It doesn't give them the satisfaction and the taste.
I see. Perfect. Thank you. So Brianna, sorry, would like to know if the cancer has already metastasized, when you catch it, how do you know where it started?
Actually, that's another really good question. The pathology will tell you a lot of times. So we've had patients like this. They show up and all of a sudden they have a liver full of tumor and nobody really knows where it started or where it came from. We'll biopsy that. We will in the OR, we'll do a laparoscopy and get some tissue, or we'll send them to interventional radiology, which are guys that use, the radiologists that are trained in procedures, and they'll stick a needle in it using CT guidance. And the pathologist can actually tell under the microscope where the tumor originated. They can say, hey, or they can at least pretty much guide us. They can say, hey, this is melanoma, or this is GI origin, probably colon, and that can guide us. And so if we see something in the liver and biopsy that, and we send it to the pathologist and they're like, oh, this is some sort of a GI tumor, we'll send patients to get a colonoscopy and an EGD and try to find the source of the cancer.
That's interesting. Let's see. Asta is asking, what is your specific role in these esophagectomies?
So we either do them robotically or open. So robotically, I'm actually, this is kind of a cool picture because this is what I see when I'm helping my boss. We'll lift the liver up and the stomach's right here. So my boss, probably should have put a picture on here, but my boss sits at a console. He's not scrubbed in. He uses the robot, and it's basically like his hands are in a little device like this, and wherever he moves his hand is how the instrument in the abdomen moves. So he has cutters, burners. That's not very scientific language, but basically he has instruments inside that move things, cut things, trim things. And then I have a hand inside as well with a grasper. And so I assist him. I hold this up for him to cut through this tissue, or I have the stapler to cut the actual stomach, or I help load his robotic stapler to cut through the stomach. I pass him all the needles. If we've got a bleed going on, I know that I have to get my suction in there, help clear the area, guide him to where the bleeding is. If he needs a clip, I hand it to him. Yeah, that's kind of it. So basically anything that you would do as a first assist, no matter what it is what I'm going to do during this surgery. So everything that needs to be done that he isn't doing.
That's really cool. So does an esophagectomy have a similar effect as a gastric sleeve surgery just because you're removing part of the stomach?
Yes, so it's a different type of surgery, obviously, because in a sleeve, you're sleeving it up, you're reducing it. So we are reducing the size of the stomach, and a lot of our patients will lose weight. But because they still have, 75, 80, whatever % of their stomach, they can ultimately eat normally. And if you think about a bypass or sleeve procedure that fails, it's because the stomach has stretched out. And so that's what happens with our patients. Their stomach kind of stretches out back to size, and then they start maintaining their weight.
Awesome.
That's an interesting connection between those two. That was a good question.
Yeah.
But I think we have one more case study question, and then we'll save the rest until the Q&A then.
Okay.
So Mariel wants to know, are there some people who are traumatized in terms of not being able to eat due to surgery?
I haven't met anyone specifically. There's been some people who've been traumatized from hospital stays, but most people, well, I guess a little bit, where they've had it where they felt so bad and they vomited so much where they actually don't want to eat. And I think that's kind of where what you're asking. And we just have to encourage them, if I need to leave the feeding tube in a little bit longer because they're afraid to eat, I do that. If they need to use their feeding tube and they only want to drink liquids for a while, that's fine. But I have to see them, every couple of weeks or at least once a month to say, okay, what are you eating now? Do I need to get you in with a dietitian to talk about this? Or maybe every day you try one new item of food and okay, it feels good. See, okay, let's try something a little bit more. That's not a huge problem though. Most people are actually really excited to be able to eat. They know they had a problem. They know the reason why they couldn't eat. And so now that they're open and I tell them they can eat new things, they go all out. I had a patient who was 3 weeks after an esophagectomy, and I really wouldn't recommend this, but this guy was, eating steak. And I was like, well, okay, so your appetite's fine. But yeah, a lot of people are actually pretty excited about that. There's not a whole lot that we have to kind of work them up to it.
Awesome, thank you. Those were great responses. You were able to answer like a lot of the other questions indirectly since you're so thorough.
Good. Okay. Well, those are actually really good questions. Okay, so I'll go to number 2. This one's a little bit different. Everyone talks about, dermatology and moles and this. I kind of wanted to talk about it from when they get to us. So Miss K is a 41-year-old. She presented to her dermatologist. Her chief complaint was a growing mole on her upper back. She noticed it about 3 months ago, not sure how long it's been there. She was changing her shirt, scratched the area, it bleeds, it scabs over, but never fully heals. So what are you going to immediately think? And everyone's going to say melanoma because that's the big one, or you could say skin cancer. And yes, it is. So here's what her dermatologist saw. And again, I just grabbed a random picture, but you're just going to could be scabbed over or whatever. So now what? Definitely biopsy this. And we worked with some fantastic dermatologists. I don't know a dermatologist who wouldn't biopsy that. Don't wait. The longer you wait, the worse it is. Don't send someone off, call me if it changes. It's easy to biopsy something like that. So her dermatologist shaved the mole. And again, I know I'm probably going to do some super detailed stuff, but here's the pathology report. Melanoma, depth of invasion. And I put this on here because that's very important. I'll kind of talk about that in a minute. Ulcerated, some other things in the pathology. There's more than this, but you want to look at margins. Microsatellites, meaning is there a little bitty baby melanoma kind of over here next to it? How fast is it growing? And the invasion is important because that tells you how thick, here's your skin, how deep down is your melanoma growing? And the depth of that is going to tell you whether it's riskier, has it gone to potentially a lymph node? So this patient definitely needs surgery. You got it out, but that's an invasive melanoma. It's not early. She needs that taken out. So she needs what we call a wide local excision and a sentinel node biopsy. And that sentinel node biopsy checks a lymph node because she's high risk. It's 1.2 millimeters. This could have gone to her lymph nodes. And this is why I tell people to get their skin checked. You can avoid a trip to the OR sometimes if this lesion is shallow and you don't need a sentinel node. If it's an early melanoma, we'll get people where they've got a little something on their arm here and it doesn't need a sentinel node checked. If they're okay with, local and they don't need to be put out, and, we can go ahead and numb them up and get that melanoma out right then and there. If it's not a super deep one, we'll get good margins. We'll numb them up really well. But you can avoid surgery sometimes. So find these skin cancers early. And this is what shocks people is the defect can be really large depending on how big the margin needs to be. So if you think about if my pinky is the size of the melanoma, well, if it's melanoma in situ, so shallow, you need a half a centimeter margin. So 5 millimeters is, if anyone's familiar with the metric system, 5 millimeters is small. That means in addition to taking this out, you need 5 millimeters of normal tissue. So you're going to go 5 millimeters here, 5 millimeters here. Well, all of a sudden, your your hole that you're making is this big, well, then think about it. You can't carve a circle out of someone. You have to make it to an ellipse. So you go from here, and then all of a sudden it's this long, so you can actually close that. And then look at this, you know, if your melanoma is around 1 millimeter, if you recall that the one that we just talked about was 1.2, so you have to take a centimeter margin. And the bigger it gets, you get up to 2 centimeters. And think about it. So now it's 2 centimeters on either side. And if you recall, 2.5 centimeters is an inch. So you're just under an inch of a margin on either side, plus however big your tumor is. You've got this. Well, now how long do you have to make your ellipse so that you can close it? So people end up with these big whacks on their back for something that's, you know, like this. So you can imagine how large that incision can get. Here's a great example. This person didn't heal super well, but right here, there's the scar from an excision. So their spot was probably right there. Could have been that big, could have been that big, but all of a sudden they have this big, huge scar. Yeah, and for this, well, where did the lymph node go? Where would melanoma go? Could be something on the neck, could be something on the underarm. Here's where we get plastic surgeons involved. Again, not my patient, but depending on where this spot is, like for on this lady's cheek, well, you know, you don't want to whack a hole in this lady's face and just try to cover it up. You're going to give her a weird cheek lift. So we'll bring plastics in. They do these really fantastic flaps and advancement transfers and all sorts of crazy stuff that I don't even know about. It just, over time, these heal and they look beautiful. So the patient comes back to surgery. We send the new specimen and we send the lymph nodes. Well, now what does your path report say? Invasive melanoma, we knew that. T3BN1. T3 doesn't mean stage 3. It talks about how thick the melanoma is. So that says still pretty thick, and you had a lymph node involved. N1 usually means 1 to, I think it's 3 lymph nodes. So we have a couple lymph nodes involved. Well, this person needs further workup. Just for the sake of discussion, I'm going to say that this mole, I think we said it was on the back, and I'm going to say that the lymph nodes were in the underarm, okay? So this patient needs a PET scan. We talked about that with the esophagus, and actually a visit with medical oncology because she may need more surgery. And I say may because sometimes we do not go back to take out the rest of the lymph nodes. Most people we do, but what if that lymph node was not completely full of cancer and just a little, like a little microscopic spot? We'll look at the PET scan. We'll talk to medical oncology, you know, depending on if they're going to do traditional treatment or a trial. That's where we make that determination after talking to them. But most patients, we're going to recommend that they get the rest of the lymph nodes out. And that's called a dissection. And the reason we don't just rush right into that is because when you take out the lymph nodes, which are responsible for moving fluid, you cannot have blood pressure checks on that arm. You cannot have blood draws. You're higher risk of infection, a risk of swelling. So we do, you know, take into account that before just recommending, hey, just do this. Here's some good things to remember. Melanoma, A, B, C, D, E. If you think about a mole, is it asymmetrical? Like is one side kind of growing, the other side's about the same? Is the border a little odd or is it smooth? Is the color, is it changing? Is the diameter, is it growing? Which I guess is kind of the same as evolving. You could say evolving going up, meaning it's getting thicker this way or it's going up that way. Sunscreen, not every melanoma is caused by sun exposure. It could be a genetic thing, but there's certainly some melanomas that are caused by sunburns over time. And so we always recommend sunscreen. I always tell people, go to your dermatologist. After we've operated them, I send them back to see their dermatologist every 3 to 4 months for a couple of years. And that's it. That one was a little bit quicker. I talked a lot longer than I meant.
Oh yeah, that was awesome. You're so good. Like it's very easy to pay attention to. So
Yeah.
Okay.
Yeah, we appreciate it. Yeah, you have a really good personality for this. So there were a couple questions just about that case study, and then we'll go into the more general ones.
Okay.
All right, perfect. So Ava wants to know, how do you check the depth of the invasion?
It's a pathology thing. So when either the dermatologist shaves it or does a punch biopsy, which is almost like a hole punch, the pathologist actually takes that, they put it on slides, and they can measure with their microscope saying, hey, how thick is this? So it's not us, it's actually a pathology thing.
Awesome. And then Brianna's asking, do you work with derm PAs when working up patients with melanoma?
No, they refer to us. So they'll do the biopsy in the clinic. It comes back as melanoma. If it's an in situ, so an early melanoma, some dermatology offices do the procedure there. I've seen that occasionally, but usually they just refer to us. So I call them if I have questions or they have questions, but we don't work together on the workup.
Got it. And now for a more general question, Lindsay is asking, where do you recommend they get letters of recommendation from?
I would do teachers in undergrad. I used a professor from my A&P class because I was missing, I think, 2 classes for my prereqs. And so I took A&P this summer before I applied, and I actually had that guy write me a rec letter. A couple of the doctors I worked with in my job before PA school, I think I got 2 or 3 of those docs to write me a letter. A pastor, if you go to a church or whatever religious thing you go to, you could do that. Wherever you volunteer, if you shadow, ask the PA, ask the doctor. I would bombard everybody. There was actually a scribe that worked in my office that was applying for PA school, and she asked me, and she didn't actually shadow with me, but we worked together all the time because the doc she scribed for is a colleague of my doc. So I knew her for several years. So she asked me for a rec, and we actually didn't even shadow, or she didn't shadow me. So I'd try everyone.
Awesome, thank you. Heather's asking, how has virtual telehealth been for you, and has it changed your experience?
It's changed it a little bit. I actually don't do a lot of telehealth, to be honest, because usually most of my post-ops, I have to see my patient, whether it's for a wound check or taking out a feeding tube. So a lot of those I would still see in the office. If it was a patient that had like a laparoscopy and a couple of poke holes, I would call them. If they're doing well, they're doing fine, I would talk to them about their pathology, and I would just cancel their appointment and tell them to call me or come in if needed. My boss actually does a lot because for scan follow-ups, we just call them and talk to them and say, hey, we're going to do surgery, or hey, we'll see you in 6 months. So it's changed my life a little bit, but not that much. It just mainly was fewer people in clinic, which is fine with me.
Thank you. So kind of piggybacking off of that one, Jennifer would like to know, how has life changed in the OR during COVID? She says, I know you guys get patients tested before then, but what extra precautions and measures do you have to take prep and actually go through surgeries?
Oh man, it's been crazy. Things have changed so dramatically since March. I'm in Texas, so we shut down for 8 weeks, 6 weeks, I can't remember. And the hospitals were actually stopping all elective cases and anything that wasn't basically life-saving. Being in oncology, most of our cases had to go. If it was a breast patient, we would kind of push them off a little bit, maybe get another dose of chemo and hold off on that. But most of our stuff, quite a bit, actually just it had to be done. We did have a really slow period in April. I think it was a couple of weeks where we had maybe a half a dozen cases per week. We were all wearing N95s, and over the summer, tests became more available. Our hospital actually, like you mentioned, does test everyone preoperatively. And we have a special, I think we have 2 ORs that are specifically for known COVID positive patients, and we operate in there if we have one that's a positive, and obviously terminal cleaning, like basically in-depth cleaning, are N95s, and then all the other rooms are clean rooms, if you will, where they're COVID negative. An interesting fact, I don't know if people know, but they're actually not recommending repeat COVID testing. If you're positive, that's it, because you can actually remain positive for, I think, 6 weeks. There are new rules, I don't know, guidance, whatever, is saying you don't retest someone within 90 days because they'll be asymptomatic and they'll pop positive again. So trying to wade through that. Other than that, I don't know that it's necessarily changed. Like I said, we have our N95s, we have the COVID rooms, we're testing everyone. We don't go to the COVID floors in our hospital. Those are almost sealed off. They have a separate ventilation area, and we don't even go in there unless we really have to. I hope did I answer that? I think I got off on a tangent. Hopefully I answered the question.
No, yeah,
absolutely.
You did great. And let's see, Adriana's asking, how do you treat patients with a known BRCA1 or 2 mutation?
Sorry, what was the last part? They have a BRCA 1 or 2, and then what did you say?
And then say, but do not currently have breast cancer.
A couple of ways. So if they have that, so the risk for breast cancer goes up, and then like a gynecological cancer goes up. I don't really know specific. I'm sorry, I don't do gynecology. So we'll caution them. If they don't want surgery, they want to keep their breasts, we say, okay, we can calculate their risk. The risk is elevated, obviously. They can either get really good routine follow-up. I've got some ladies that get a mammogram every year, and every other year they'll get a breast MRI, just because we know that chances are they're going to get something, and we just follow them closely. Some people say, hey, look, I don't want to deal with this risk. I want what we call prophylactic surgery, meaning I don't have cancer, but my risk of cancer is so high, I want to do something about it. And we actually go and we get, we take off their breasts. We do a mastectomy for them. They get a reconstruction, and that's what we do. So that from a surgery standpoint, those are really the two options: either really close follow-up or a mastectomy. Once they've had a breast cancer, from my standpoint, it doesn't change anything. I just know that they have that. Their oncologist may say, hey, do you need to visit with a gynecologic surgical oncologist? Because do you need something else taken out from that standpoint? Or it's not necessarily going to affect their chemo, and it doesn't change my surgery because they've already got a cancer. We know that. They have a BRCA. Well, you still need a surgery.
Awesome.
So Gwen is asking, how would you rate your autonomy as in surgical oncology versus other specialties?
I could probably have more if I wanted. So if you've got like a pediatric clinic PA, they're probably not even going to talk to their boss that often, or their supervising physician. I call him my boss just because we get along so well, but they're probably not going to talk to their supervising physician all that often. Maybe they'll see him once a day. Maybe they'll see him a couple times a week. They have their list of patients, they make their decisions, and they move on. For us, it's a little bit different because I do work with him and I cannot operate alone. You have to have a supervising physician in the OR to operate. So I'm kind of stuck with him just by nature of being in the OR. In clinic, though, I could be super autonomous if I wanted. It works really well. Sometimes the patients like to see him. But yeah, I see there's many clinics I'll go through and I don't have him see a single one of my patients. I'll take this person's feeding tube out. I'll take this port out. It's cool. You make a little incision in their skin and kind of dissect down and take the port out. I'll, diagnose this infection and start them on antibiotics and say, hey, here's your pathology report. You need to see a chemo doctor, and I'll refer them there. So I could probably have a little more, but our current workup just flows really well for us. So if you're someone who's wanting to do your own thing, see your patients, clinic might be a little bit better for you. But it doesn't bother me just because I enjoy being in the OR and get along well with my boss. So we're just kind of everywhere he goes, I go.
Wonderful. Thank you. You two seem to have a really, really great relationship.
Oh yeah, he's great. He's ridiculous, but he's great.
Becky would like to know, what's a general case that you typically enjoy?
Gallbladder. It's not cancer at all, but it's a gallbladder. My boss and I have our system like to a T. We can take a gallbladder from cut to closing them. Our fastest one, I think, was like 16 minutes. Like, we have our system. And I also like putting in feeding tubes because I get to do a lot. If we're putting in a tube in the stomach, you can put it in either laparoscopically with, cameras and instruments, or you can put it in, we call it percutaneously. So basically someone will run a scope down the throat to look at the stomach, and then someone will be at the patient's belly. And speaking of autonomy, this is fun. So my boss runs the scope and he looks at the stomach, and I will stand at the patient's belly. And this is kind of awkward, but you can see I'm not wearing scrub bottoms because I changed. I will poke here on the patient and I will find their stomach. And if I push and my boss is looking with the scope, he can see the stomach kind of indent from me pushing on the outside. And we know, hey, this is exactly where the stomach is. And we'll take a needle and I'll sit there and I'll poke the needle right in. I'll feed the tube in, and he and I work together, him at the mouth and me at the belly, to put it in. So those two are probably like some of my most favorite ones.
Awesome. Emily would like to know, do you find that this specialty can be emotionally draining since you're primarily seeing cancer patients?
Oh, yes, totally. It's horrible sometimes. And the good thing is it has taught me to appreciate life, because God, I could die tomorrow. And I know that sounds really dark, but you really don't know. I mean, I've got people, the stories that bother me the most are someone that worked hard their whole life. I'll take that vacation when I retire. You know, we'll do this when I retire. We'll do this when I retire. And I've got these stories where someone retired and 6 months later, they've got a horrible cancer and they're not going to do all those things that they wanted to do. So it's made me really appreciate. And I tell my husband, it's like, if I have to go tomorrow, I want to know that I did or was doing everything that I wanted to do. I'm not waiting until I'm retired because I don't know if I'll get a retirement. Again, sounds really dark, but you have to live your life. And another thing is, speaking of dark, is we have really dark humor. And I know some people won't understand that, but if you can joke about a situation, obviously respectfully, you're not doing this to the patients, like, hey, you know, you're not talking to someone because patients aren't in that frame of mind. But if you can joke about wherever you're at, it makes things a bit easier. Otherwise, I'll sit in the corner and I'll just be crying. You know, I had a patient die on the table, and that was the worst day. And I went to the ICU, and someone consulted us. You know, this patient has terrible disease in their belly. Can you help them? And there was nothing we could do. And like I can't forget it. You know, we told this person and their family. I said, hey, you know, we can't help you. There's no surgical option for you at this time. And this patient's sitting in the ICU, and there's just one sad tear just came down their cheek. And I can't forget, it's been years since I saw this patient, but they were holding out hope, and they were really young. They were in their 20s, and there was nothing we could do. And I thought about that all day, and that's what the margaritas come in. But just to say, yes, the days are really hard, but you find ways of dealing with it. And you learn to live life to the fullest, I guess, which sounds super cliche, but it's true.
Thank you for that. That's a, you know, kind of a more personal thing to discuss. So I'm sure a lot of people were wondering about that. You definitely seem like more of a mentally tough person. But
I hope so. I don't know.
from the brief time that we've gotten to know you, you're, you know, always so charismatic and happy. You would never imagine that this is your job, you know. So thank you so much for that. Let's see. So Lindsay is asking, do you feel like you have a good balance between seeing awake patients, informing patient interactions versus seeing patients during surgery?
Well, it depends. Me personally, 100% being asleep would be nice. But yes, to be honest, yes, it's a good mix, because I'm in the OR a decent amount of time. So we operate all day Mondays, Tuesday afternoons, and Friday afternoons, and all day Wednesday. So Monday, Wednesday, full days, Tuesday, Friday, half days. And then our clinic is Tuesday, Friday morning, and all day Thursday. So my boss actually changed it. We used to do clinic on Mondays, and he changed it to an OR day because no one wants to come in and do clinic after a weekend off. And that's actually helped tremendously. So we go right to the OR, we do everything. And yeah, the mix is good. The mix is actually really good.
Perfect, thank you. And I just want to make sure we're being respectful of your time and not going over or anything like
No,
that.
I'm okay. I have a couple more minutes. Oh, we did go actually pretty long. I've got a couple more minutes, but I've got to put some notes in on my consults and make sure I don't have to go back to the hospital.
Okay, sure. Well, if it's okay, maybe just one more question.
Oh yeah, no, totally. I've got a few more minutes. We're fine.
Okay, so maybe, what do you think, 2 or 3 more?
Oh yeah, no, that's good.
Okay, perfect. So somebody's asking, how long have you had your current position?
Oh, okay. I'm going to give away my age. 9 years in January.
Wow, that's awesome. I never would have guessed.
Never.
Yeah, I try not to give away my age because then I feel old. But yeah, I graduated December 2011, and I started with him January 2012.
I
So
see.
we're up on our anniversary soon, and I like to give him. He has to give me something every anniversary. Last year it was. I don't know if everyone knows this, but Tiff's Treats is a cookie delivery company, and he always sends me a card and cookies, and and he always sends me something for my birthday. So he needs to get it together for year 9.
Yeah,
Oh,
definitely.
awesome.
It sounds like it. Somebody's asking, do you feel like you still have time for your husband? What are your hours usually?
My hours are really good. I really, really can't complain. Like today, like I'm at home. So we have a satellite clinic that is in, it's like 2 hours-ish. Sorry, I'm checking my phone. 2 hours-ish away from Dallas. And my boss goes there once a month. And I went with him one time, but I never had any patients on my schedule. And that's fine. I could work as an MA, which again, doesn't bother me that much, but he has someone there that MAs for him, which is the rooming the patients. So I just round. So like today I got up, I was actually able to squeeze in a morning workout, which I never do because I am not a morning person, but I had the time. I didn't have to get up early, and that's the only way it works for me. So I went, worked out, I rounded, I saw the post-op, the 2 new consults, I came here, and as long as I don't get called back, because we are on ER call, remember, as long as I don't have to go in for a case, I'll just work from home the rest of the day. And that's usually once a month that I get to do that. Typically, Monday OR day, I'm almost always out by between 2 and 4. Tuesdays, Tuesdays and Thursdays are usually 8:30 to 5. Wednesdays, my boss hates to start early. Our cases usually start at 8:30 or 9. He has 2 girls. He wants to spend time with his family. So if it's Wednesday, it's not like today. It's an OR day, so we're 8:30 to 5. The latest I stay is the vast majority of the time I'm out between 4 and 6. Occasionally we'll have, the OR is running slow. We got an emergency we had to add on to our already full day. I'll leave 6, 7, 8 o'clock. One time my boss called me at 3 in the morning because our patient was bleeding. That rarely happens. So I would say generally I'm there between 8:30 and 5. I don't work weekends. I don't take call at night. On Fridays, if I can get out at 3, my boss already knows I'm going to go get my margarita, and he's like, well, you'll be drinking by 5, and so it's great. It's a great work balance.
That's amazing.
Awesome.
That's good to hear. So maybe one more. I think this is a pretty good one to end it on, if that's okay with you.
Yeah.
All right, perfect. So they're just asking about your opinion on the future of PA. So if you could discuss things like salary or saturation in the market, or their role of medicine and how that's going.
Oh, I know there's a lot of issues. There's a name change issue. There's independent practice issues. I think salary is always going to be fine. I think as a PA, if you're lowballed, unless you're just dying for the experience, wouldn't necessarily take that, because usually if it's a low salary, they don't really have respect or understanding, one of the two, for PAs, and they're not going to treat them well. Saturation, I feel like we are in a way, but my entire class, granted it was 8 years ago, my entire class found a job within a couple of months. And most of the PAs that I meet or know or follow, like a lot of them are finding jobs right after graduation. So I think there are some areas that saturated. I think my Metroplex, I hear, is getting saturated, but I haven't personally really met someone who didn't find a job if they were looking for it. Usually you can get one, if not in the first couple of months, at least within a year of graduating. Now, I know there's a lot of stories. I don't think I personally have really met anyone with, actual trouble. Let's see, it was a question about salary. Oh yeah, future. So there's the name change issue because physician assistant, well, I guess I assist my doc because I'm in the OR, but most PAs are in clinic. They're on their own. They're doing their thing. They're not assisting the physician. They're doing their own thing. So they're talking about changing. I think physician associate is one of the recommendations. I like that name. I asked my boss about it. I think he and I are an anomaly because I don't understand terrible physician-PA relationships, because he and I get along so well. He trusts my judgment. He doesn't give me a hard time if I have a question for him. Like, he's always available. Yeah, he's impatient, but I learned to work with him, and I know when he needs his time and when he needs his space, and he knows when I'm upset. Like, I told him one time, I was like, I'm not talking to you because I'm mad at you. And he kind of, huffs and puffs, and then we're fine. So I don't understand the bad relationships. I think it's a lack of respect and it's a lack of understanding. So I'm obviously not opposed to changing the name, but at the same time, you change the name, that's not going to change someone's mindset. Someone who didn't respect you as a physician assistant isn't going to respect you as a physician associate. And that doesn't make them understand your role any better. Maybe from a public's perception, like a patient, they may say you're seeing the physician associate. Maybe that might help how they see you, but it's still going to be abbreviated as the PA. My office says, you're seeing the PA. So I don't think it can hinder. I think it can help, but you still have to change the mindset of the people out there who don't know or understand or respect a PA. And then I know there's a whole lot of back and forth on the independent practice. I haven't looked into a lot of it. So I really don't want to go down the wrong start saying the wrong thing. I know it has to do with allowing PAs greater authority. Right now, a doctor can supervise, I think, I think it's 6 PAs, and I think they're increasing that number. They've released a lot of the restrictions on where your doc has to be. Usually you had to be, within 60 miles, you had to contact him. So they're making it easier to practice, but I think some doctors, and no shade because I love my doctor, are worried that PAs are trying to take their job. And I think PAs are going into this wanting to help and be that missing piece. And so I think there might be some misunderstanding, some PAs who probably aren't the nicest, some doctors who actually do hate PAs. And I think we're only hearing about the sides as opposed to the happy middle. Like, I'm very happy. Like, I'm quite happy. If you don't change the name, I'm fine. If you don't change my authority, I'm fine. But you've got the outliers, and that's all we hear about. So I hesitate to say too much, even though I'm still saying too much. I think it just really depends on, you can't just change people by changing a rule.
Yeah, sure. You bring up a lot of very valid points. So thank you very much for that. I think that's a great place to wrap it up, though. We really appreciate you joining us. We know you're on call and still you got some work to do. So thank you so much for taking the time out of your schedule to do this with us.
We really appreciate it. Yeah, thank you so much. And
You're welcome.
you for everything you do as well. I know your specialty is really hard, so a lot of respect for that. And we really enjoyed your presentation. You were very easy to follow. I wasn't familiar with a lot of the things you were talking about, but you made it very clear and easy to follow. So you're a great teacher.
Awesome.
Yeah.
All right. So I think this is where I cut out and then y'all finish, right?
Yeah, definitely. And just to kind of give you a heads up, I know you might go back and look over some of these responses, but everybody, there was a ton of support in the chat. Everybody was saying thank you. They appreciate it. Like, all of this, they really loved you.
Awesome. Well, if anybody has any questions, message me on Instagram. Sometimes it takes a little bit to respond. I try to respond within a day or two, but message me if you got questions. It's cool.
Yeah, for sure. Well, please make sure to follow her. We'll put your Instagram link in the chat so that anybody that wants to go and take a look at your page, follow, definitely.
Okay.
But yeah, well, thank you so much. We really appreciate it. We learned a lot today.
Awesome. All right, now I got to figure out how to get out of here.
All
right, I think I found it.
Okay. All right. Thanks so much. Have a good one. Take care.
Have a good day.
All right, everybody. Thank you so much for joining us. We're about to put the quiz in the chat right now. Like we said before, if you have any questions about anything, we'll be hanging out right here so y'all can let us know. We have a couple sessions as of right now coming up next week. What's the next one? The 25th?
30th.
Oh, 30th. Oh, today's 35th. Okay, so next one's going to be in 5 days on the 30th. And we will keep you posted on Instagram about all the upcoming ones. Yeah, I think that's everything. Quiz is the usual, right? 4 out of 5.
I just sent the link out to it and I pinned it. So there should be like a little blue box at the top where you can see it. And if the chat scrolls more, it'll still be at the top. As long as you answer 4 out of 5 correctly, you do get a certificate. It is open for an hour. So at 2:35 p.m. Central, that the quiz will automatically close. I think that's it about the quiz.
All right, perfect, guys. So thank you so much
for joining us.
Yeah, we'll be right here. If you want to ask us anything, just let us know. We'll see you next time. Take care.
Bye. Oh yeah, one more thing. Happy Thanksgiving for tomorrow. Hope everyone enjoys their holiday and stay safe.
Stay safe, guys. Yeah, hope you guys have a good break. Thank you again.